First of all, I'd like to thank the organizing committee for having me. My talk today is about the role of echocardiography in cardiac trauma. And to highlight this important topic, you have to know that about 25% of trauma deaths is related to cardiac trauma, and it is either a blunt trauma in 70% of patients and penetrating trauma in another 30%. This penetrating trauma is maybe either stab wound or gunshot. So when you have a trauma in this, what we call cardiac box, this space bordered by the mid-clavicular lines and the clavicles on both sides and the costal margins, so you have to suspect that there is a cardiac trauma. This box does not include only the heart. It includes the heart with its pericardium, the great vessels, the esophagus, and the intrathoracic trachea and main bronchi. This penetrating trauma, when you have diagnosing a penetrating trauma, so you can suspect that the right ventricle is the most commonly chamber to be injured. VSD is the most common intracardiac injury, and when you have a blunt trauma, you can have myocardial contusion, coronary artery injury, and atrial or ventricular chamber rupture. Regarding the role of echocardiography in trauma patients, before we say that, you have to imagine the circumstances. You have a polytrauma patient or a stabbed patient with a lot of blood in a room with running doctors and nursing and maybe relatives around you. So it is not the very common situation that the echocardiographer can work in. So, but you still have a rule in this trauma patient, and your rule is to evaluate the cardiac as well as non-cardiac trauma patient, not only in the trauma resuscitation phase, but also you have to follow up this patient in the critical illness period. And often you have a very limited time, and a detailed echocardiography looks to be difficult to have in this situation. In the resuscitation scenario, you have to adapt a more focused protocol for assessment of your patient, just to get through the life-threatening cardiac injuries and to handle with it. In the post-resuscitation phase, you have to continue rule by echocardiography to unmask maybe a pre-existing cardiac pathology or trauma-related pathology which may influence the management. You still have a transesophageal echocardiography because you don't have a good echo windows from the transthoracic cardiography. This is a case presentation to illustrate some of this rule. You have a 30-year-old male patient with no previous cardiac past history, and he had an anterolateral chest stab wound during a street fight and presented to your ER. Shocked with 70/40 millimeter mercury, steady rapid pulse, and with overt bleeding, and the assaulting instrument is already removed. Emergent focused protocol showed an pericardial tamponade, and he went for emergency thoracotomy. With the operative data we got from the surgeon that he has an RV anterior wall tear with simple suture repair with the evacuation of the pericardial hematoma. Patient was, thank God, stabilized and discharged 1 week after. And 3 months later, he came complaining of dyspnea grade 3, orthopnea, BND, some heart failure symptoms, and referred for a follow-up echocardiography. This is a post-resuscitation phase. So this transthoracic echocardiography showed in the parasternal long axis, we can appreciate here that there is a significant mitral regurgitation, and you may have a suspicion that it is not coming from the orifice of the mitral valve. Actually, it is coming through the posterior leaflet, through a rent in the posterior leaflet measuring about 4 millimeters. And in the apical windows, you can appreciate that he has some sort of mild left ventricular systolic dysfunction. And again, there is a mitral regurgitation, which looks dense and significant. But now you can appreciate in the two-chamber view there's another rent in the anterior left ventricular wall. There is a tunnel-like shape in the left anterior ventricular wall, with the blood is swirling inside this rent. This is again confirmed in the short axis. You can appreciate this rent in the anterolateral wall. And the ejection fraction is about 45 to 50%. We went for transesophageal echo. You can here appreciate that in the left atrium, you have some defects in the posterior wall of the left atrium. focusing on this defect, you can see that there is a very similar rent in the posterior left atrial wall like we saw in the left ventricular anterolateral wall. But there is no swirling color coming in or out from this rent like in the left ventricle. Again, there is a mitral regurgitation coming out from the rent of the posterior mitral leaflet. This is the rent. And looking for the rent in the left ventricular anterolateral wall, you can see it is not that small, it is a large one. It lengths about 2.6 millimeter, 2.6 centimeter, sorry, and its width about 0.5 centimeter. And if we postulated our hypothesis for this stabbed patient, that this is the knife coming out from the anterolateral left ventricular wall through the posterior mitral leaflet to the posterior left atrial wall. This is the track of the stabbing instrument. And we sent him for cardiac MRI, which confirmed all these findings. So this patient was referred to surgery. Referring back to this editorial comment published in JACC 2020, and they said that the diagnosis of cardiac trauma is usually not easy, and ultrasound evaluations through the EFAST protocol is a method of choice to provide initial information about the presence of pericardial effusion with a sensitivity of 100%, specificity of 97%, and the gross changes, just the gross changes of the function and the structure of the heart. Subsequently, you have to go more thoroughly and to do a comprehensive transthoracic echocardiography post-resuscitation phase. Should be performed in all patients with blunt chest trauma or even refractory shock without a clear etiology for the goal of identifying these changes that may require immediate intervention. This is the EFAST protocol, which symbolizes for the extended focused assessment sonography for trauma. And we have 6 basic views. The subcostal view for the cardiac structure and function and pericardial effusion, the right upper quadrant view for the liver and lung and kidney, the left upper quadrant view for the lung and kidney and spleen, the pelvic view for the bladder, and right and left anterior thoracic views for the pneumothorax and the hemothorax. We have guidelines published by the ESC in 2013 for emergency echocardiography, and they said that echocardiography is recommended in patients with severe deceleration injury or severe chest trauma to detect pericardial effusion, myocardial contusion, laceration, wall motion abnormalities, valvular irritation, aortic dissection. But in patients with mild trauma, mild chest trauma, without ECG changes or biomarker elevation, you don't have to do and delay your patient for a routine echocardiography. So why not to do echocardiography for all trauma patients? Because there is a limitation for the use. The patient is unstable with a poor image quality, and the time is very short. So my take-home message, that when you are doing a focused protocol, you still have to provide information, and framework of your job includes, you have to tell information about the volume state of the patient. Is he overloaded or depleted, volume responsive or not? You have to tell about the gross function of the left ventricle, right ventricle. You have the gross function of the valves, if there is pericardial effusion, is there an aortic dissection, and other non-cardiac causes for shock, like hemothorax, pneumothorax, maybe, or hemoperitoneum. This is the second take-home message. You should have a situational awareness. You don't have to go with your clean white coat in a room full of blood, with circulating doctors, and drinking your hot coffee, and you say, I will do a routine echo in half an hour or 1 hour. So this is fire around you. So you have to take care not to be the next trauma patient in the room. And thank you.